بسم الله الرحمن الرحيم. أرحب بكم وأتمنى لكم ميتنج مفيد ووقت سعيد. مشاركتي أحب تكون بتوك عن التوتال ني arthroplasty after upper tibial osteotomy. The effect of osteotomy is well known that it leads to load distribution and reduced stresses on the diseased compartment. It stops the disease progression with some claims that it leads to cartilage regeneration, the correct joint mechanics, and this improves symptoms, especially by pain relief by many mechanisms. There is 5 basic types of upper tibial osteotomy: the lateral closing, the medial opening, and the lateral closing medial opening, which largely in the big area, in the large degrees of deformity, and it's replaced the dome osteotomy and the calotasis. The natural history of upper tibial osteotomy, however, it deteriorates over time, with 80% satisfactory results at 5 years, 60% at 10 years, and average satisfactory 7 years. That means that about half of the patients will require conversion to total knee arthroplasty at 7 years. The total knee arthroplasty after upper tibial osteotomy, its clinical results were inferior in those with previous upper tibial osteotomy, had lower knee scores, more pain, higher risk of revision and complications than with those with primary total knee. There is a higher risk of infection after external fixator used techniques in upper tibial osteotomy, definitely. Difficulties caused by upper tibial osteotomy in the skin, the soft tissue scarring and adhesions, difficulty of surgical approach, the metal inside, the knee stiffness, the lower patella, the anatomical distortion of the proximal tibia in the coronal, rotational, and slope, and higher reading of fibula in lateral closing types. Ligamentous imbalance and choice of implant, and lastly, possibility of dormant infection. In the skin, difficulties, the transverse and diagonal scars can be ignored safely and go for straightforward skin incision. If the patient had multiple longitudinal scars, these are vulnerable, especially the lateral flap, since the blood supply and lymph fluid drainage are mainly from the medial side. The skin incision can be made from the far lateral previous incision, if there are many, and approach through a medial arthrotomy or approach through a lateral arthrotomy. This is the previous scar of bilateral upper tibial osteotomy, and this lady went to a bilateral total knee after bilateral upper tibial osteotomy. The metal inside, removal of all or partial removal of metal only if it interrupts the placement of the tibial components or if it is bulky. This requires equipments, time, and sometimes a lot of dissection. So in primary, can be done in 1 or 2 stages simultaneously if the staples or screws can be safely and easily removed through the same skin incision, or a staged procedure for removal if using a separate incision and soft tissue dissection is expected to be lengthy, or if you need a biopsy from query local infection. Difficulties in the surgical approach in the patellar eversion, this is the most common surgical challenge, is in conversion of total knee after upper tibial osteotomy due to peri-osteotomy site adhesions, excessive new bone formation at osteotomy, high riding fibular head, and patella baja. Every effort and stepwise release is a must to prevent a patellar tendon injury or avulsion, and if required, early release of patellofemoral ligament and lateral retinaculum release. Extensor mechanism lengthening by rectus snip, VY plasty, tibial tubercle osteotomy sometimes are mandatory, but this is not without drawbacks, and it leads to extensor leg and lower patella and weakness. Patella baja is very common, especially in closed wedge upper tibial osteotomy because of scarring and contracture secondary to slackness. The anatomical distortion of the upper tibia. Uh, the upper tibial osteotomy can correct or produce secondary deformation in the coronal, rotational, or sagittal planes. So planning for reproduction of the original joint line is a must by imaging of the good side and 3D CT if required. The coronal malalignment is the easiest one and can be corrected by total knee as they are metaphyseal and close to the joint line. Except in severe deformities, this can lead to soft tissue imbalance, and extra-articular osteotomy should be considered. Indications of extra-articular tibial deformity correction. If the angle of angulation is more than 30 degrees, if it's close and affect the joint line, and if the anatomical axis skips the joint line, as in this case. Notice that the anatomical and axis and mechanical axes are not the same with deformity, so an extra medullary guide should be used. Translational mismatch, when stem is not central and can come in contact with the tibial cortex, this can be solved by tibial component undersizing, medial positioning, and use of offset stem, as in this case. This also preserves bone stock by reducing bone cut. The bone stock can be significantly deficient in lateral closing wedge osteotomy. This requires conservative bone resection at the first stage, at the first cut primarily, and use of lateral condyle augment or graft. The slope can be markedly affected by upper tibial osteotomy. There is a tendency with upper tibial osteotomy to open the wedge more anteriorly. So in open wedge, you increase the slope, and in lateral closing wedge, the slope is decreased in upper tibial osteotomy. So perform the proximal and distal osteotomy cuts in the total knee should be done according to plan and assure adequate posterior release and sizing of the gap. Lastly, the rotational deformity. The rotational deformity can be produced or corrected by upper tibial osteotomy, but the correction of this rotational deformity by rotating the tibial component is very dangerous, as it affects both tibiofemoral and patellofemoral biomechanics. Increase in the Q angle, it's known that it leads to lateral subluxation of the patella, pain, accelerated wear, mechanical symptoms, and even dislocation of the patella. Common errors which should be guard against in this total knee that look for lateralization of tibial tubercle produced by upper tibial osteotomy, avoid internal rotation of tibial prosthesis, and medialization of the femoral component or lateralization of the patellar prosthesis if replaced. If severe rotational deformity is encountered, derotation osteotomy or medial transfer of the tibial tubercle should be considered. In the ligament balance, medial and lateral imbalance is frequently observed after upper tibial osteotomy, and bone cuts perpendicular to the mechanical axis may result in asymmetrical gap and increase the pre-existing imbalance, what's called resection laxity. CT implies use of special prosthesis. The PCL is usually contracted after upper tibial osteotomy, leads to insufficiency and may rupture after total knee. So a posterior stabilized total knee arthroplasty should be used, as it is difficult to maintain and the appropriate tension in the diseased PCL, especially after upper tibial osteotomy, with changing in the slope and contracture of the PCL. It is known that stability, range of motion, and knee society scores in PCL retaining total knee were inferior to PCL substituting TKA. Semi-constrained type prostheses should be ready and considered in excessive varus or valgus deformity, laxity, or unable to obtain accurate ligament balancing after intra-articular correction of extra-articular deformity. It's known that the upper tibial osteotomy has a long list of potential complications, especially the non-union and infection. With non-union, the non-union side should be removed from fibrous tissue with autogenous bone graft from the resection bone, or use a long stem tibial prosthesis for stable fixation and of the prosthesis and non-union, or you use a shift to a replacement type of prosthesis. The malunion we mentioned. So the take-home message is get the upper tibial osteotomy right from in the first place. Conversion of upper tibial osteotomy to total knee is a revision surgery and is different from primary total knee. Revision, previous sound upper tibial osteotomy does not compromise subsequent total knee arthroplasty in spite of a significantly higher rate of intra and postoperative potential complications and difficulties which requires special care and preparation. Thank you very much.